Arthritis with a rotator cuff tear that's not really repairable, or if you have rotator cuff tear arthropathy. It's a pretty unique form of arthritis, and this was first described by Dr. Neer. Normally, the function of the rotator cuff is to, as it fires, engages the head into the socket to allow it to act as a more ideal fulcrum. If that rotator cuff is not intact, then instead you have a superior driving force from the deltoid, and you can eventually get articulation with the humeral head and the acromion and some changes that occur with that. Some of those changes are femorization of the humeral head or an acetabularization of the acromion, but the clinical features are going to be rotator cuff insufficiency, degenerative changes, as well as, again, that proximal migration of the humeral head. Sometimes people can ultimately develop pseudoparalysis, especially if it's a little bit more of an acute change, and that's by definition an inability to elevate the arm above 90 degrees, so they're kind of leaning over trying to do a little T-Rex elevation. If they do have rotator cuff tear arthropathy, it's a definite contraindication to doing a standard total shoulder replacement, because you can get something that's called a rocking horse phenomena, and you edge load the glenoid component, and that will fail at some point. So you want to be cognizant of the rotator cuff, and again, if it is repairable. As far as some of the x-ray views looking at rotator cuff tear arthropathy, again, going back to the true AP, you can get that femorization or the acetabularization. The main thing I'm going to be looking at is the acromio-humeral distance. If it's greater than 12 millimeters, then that's a little bit too much. With something like that, it could be actually a nerve palsy or a shoulder instability, or even a current fracture or dislocation. It should be resting around 10 millimeters, about 8 to 12 millimeters in range, and that's going to be your normal. If you have thinning of the supraspinatus, that can get down to about 6 to 7. And if you look at an x-ray and there's almost an obliteration of that space, then that is rotator cuff tear arthropathy. You don't need an MRI to confirm it. It's an absolute pathognomonic. And the shortest distance is measured. So for the rotator cuff tear arthropathy, Hemi is an option, and prior to 2004, this was the main option. And at 2004 is when some things changed a little bit. In this country, we had the reverse shoulder replacement approved by the FDA, and I believe that was around November. But the nice thing about this is you don't have to put a glenoid component in. The ability to rely on restoring elevation is not as predictable by any means. So if you have a pseudoparalytic shoulder, I'd be a little cautious of just pursuing a Hemi arthroplasty, unless if they are what's called a compensated rotator cuff tear arthropathy, where they've been able to, with time, get the ability to once again restore their ability to elevate the arm. Overall, this technique is declining, especially